thank you for inviting me to share with you the work that we have been doing since March of 2020 in using data and AI to help make better decisions regarding the COVID-19 pandemic. Fundamentally, as I just said, I have been leading a team of 20 plus scientists, and we have been working together very closely with the government of the Valencian region in Spain, which is on the east of Spain by the Mediterranean, to support them in making better decisions related to the pandemic through the analysis of data using machine learning and sort of like broadly speaking AI algorithms. This is the members of the team, so it's a pretty large team belonging to most of the universities and a couple of research centers in the region. And the team came to be very early in the pandemic in March of 2020. And the main motivation for our team is to fill the gap that there is between where the data is, thinking of the data as a digital representation of an underlying reality, and where the decision and the policymakers are. And the goal is that the policymakers and the decision makers make their decisions informed by evidence. Understanding that the data is capturing the evidence, the goal will be to use the data to support their decision making. But unfortunately, there is this big gap between where the raw data is and where the decision makers are. And our goal has been to fill that gap. And to do that, we have a structure our work into 4 large areas. The first one is human mobility analysis, because an infectious disease that is transmitted from human to human doesn't become a pandemic if people don't move. So modeling and quantifying and understanding human mobility is very important. The second large area is the development of computational epidemiological models, models that are able to predict the number of cases and the evolution of the pandemic, not only under the current situation, but also under different potential scenarios. The third area has been building predictive models of hospital occupancy, intensive care occupancy, and also inferring the prevalence of the disease. And the last area is a very large-scale survey called COVID-19 Impact Survey, which we launched at the end of March of 2020. It's been running for almost 2 years, and it has over 700,000 answers from several countries, and it's shown to be a very helpful tool to understand the situation and the perception of people during the pandemic. Still, there is a gap between the output of all these modules, which is still pretty technical, and where the policymakers are. And I think a key layer for the success of our team is this layer here of results interpretation and aggregation, which has mainly been done by me in very close collaboration with the Director General of Public Policy in the presidency of the government. One of the key aspects for a team like this one to be successful is to be multidisciplinary and also multi-institutional. So this politician working for the president of the region is an active member of our team, has come and comes to every meeting and really makes an effort to translate the technical results into actionable insights that could be useful for decision making. So I think that's one of the first take-home messages from my talk, how important it is if we do want to have impact to have these really tight, multidisciplinary, multi-institutional teams working together, so the users of the results are actually an active part of the team and they perfectly understand, what kind of work is being done, and also help prioritize the work. In terms of the technical skills, everyone is scientists, from students to full professors in computer science, math, statistics, physics, with different sort of like areas of expertise. So the mobile data team has a lot of expertise in large scale data wrangling and visualization. The epidemiological team has a lot of background on machine learning and computer modeling. The predictive modelist team has a lot of background in statistics and machine learning. And then the citizen science team also has background in human-computer interaction. We have been working very intensely for many months until basically on and off throughout the pandemic. We've been meeting daily, particularly until the summer of 2020. And I've been writing reports also daily with the predictions of the day and some of the insights for that particular day on special studies from the impact of children on the pandemic, the impact of contact tracing, digital contact tracing, vaccinations, any sort of like relevant topic. We never worked together, this team, before, and we didn't know each other. So all our interactions have been using technology. We eventually met in person for the first time in the summer of 2021, so a few months ago, or in the late spring of 2021. We have a common code repository using GitHub, and we have a very active Slack channel that we constantly use. This is an example of one of our daily meetings during the pandemic. We also have an official website in the government's website, but it's in Spanish and in Valencian. Another observation is that it's actually not easy to create such a team and to actually have impact. And there are many reasons why not. First of all, a big challenge is the lack of capacity and the lack of a digital mindset in a lot of the public administrations and governments. Another barrier relates to accessing the data. There are obvious concerns in terms of privacy and data protection, but I have to say all the data that we have used in this work is aggregated, anonymized, in most cases, publicly available data. So you can do a lot with data that doesn't have any privacy implications. Of course, there is a gap between where research ends and where the real world, starts, and that's why it's so important to have these multi-institutional teams that really help cover this last mile between research and the use of the research results. And of course, in the context of the pandemic, if all the elements are not in place, it's very difficult to be able to leverage data because you have to be making decisions constantly all the time, and you don't have a lot of time to actually create an entire infrastructure, to do this. We reflect on some of these issues in this paper that we published very early on the pandemic in April of 2020, particularly on the value that data, mobile network data and mobile phone data could have to support policymaking during the pandemic. So what have we done? So I'm just going to quickly share a summary of some of the results on each of the different work streams that we've had, starting with the mobile data analysis. So as I mentioned, the main goal for this work is to really understand the impact of the confinement measures on the mobility of the population, and also the impact of the mobility on the spread of the disease. This is an example of the visualization of the kind of data that we were able to analyze since the beginning of the pandemic. Is data that has been computed from the mobile network infrastructure, and it was shared with us by the National Office of Statistics. This data was eventually made public in the summer of 2020, but we were able to analyze it since March of 2020 by virtue of having been named the pilot region in Spain by Vice President Calviño to be able to use the data. This is the Valencian region in Spain. This is the Mediterranean Sea. So we are located on the east of Spain, on the coast, and the region has about 5 million inhabitants. The data was given to us with a certain spatial granularity. We have data daily, so the temporal granularity was every day. And the spatial granularity was given by these regions here that you see, these areas irregularly shaped. And these areas fulfill the following conditions. If a municipality has less than 5,000 inhabitants, then they cluster multiple municipalities until there are at least 5,000 inhabitants. And this is to preserve privacy. Municipalities between 5,000 and 70,000 inhabitants, they have an entire region for themselves. And then municipalities that are larger, like the capitals, for example, in the region, they are split into sub areas of population. For each of these regions, we had information on how many people lived in the region, slept in the region, and then how many people enter and left each of these areas every day, as long as they left or entered for more than 2 hours. The data was originally collected to model commuting patterns in the population, and it was just lucky, it was just by luck that the project was ongoing when the pandemic happened. So we could actually analyze the data also for the pandemic purposes. One of the first analyses that we did was how successful the stay-at-home campaign was. And we found a very significant compliance in the population of the stay-at-home campaign. Of course, we don't have, here the definition of home is not the actual house where people live, is the area of residence given by these regions here. But what we did find is that on average, 88% during working days and 92% during weekends of the population never left their area of residence for more than 2 hours during the entire big lockdown that we had in the spring of 2020. Here I show an evolution of the percentage of population that stayed at home. I didn't mention this, but the greener the color, the larger the percentage of the population that stayed in their area of residence. And as you can see, some of the areas were in the upper 90s. So it was a very significant percentage of the population didn't leave the areas. As you see the evolution over time, at the very beginning of the pandemic, there are a lot of areas that are still yellow and orange, which means between 60 and 80% of the population stayed in the area. So there was a certain amount of mobility. And then during the period that we had the very strong lockdown, which was between the last Monday of or Tuesday of March until Tuesday, April 14th, you can see that the map becomes much greener because there was a very severe lockdown. There was no labor mobility at that time. And then once they open up for labor mobility, we can see that the map becomes more yellow again. To support public policy making, this geographic representation might not be the most meaningful. So in the context of public health policy making, meaningful area is what is called the Department of Health. In the Valencian region, there are 24 departments of health, and these are the geographic regions that are served by hospitals. So we performed all the analysis also by Department of Health. And here we can see the percentage of people at home during working days in reddish color, or during weekends in this brownish color for each of the departments of health. And we see that it was always above 80%, and there's a little bit of variation depending on the Department of Health. And always one finding that is consistent with the literature is that during weekends, there is always less mobility than during the week, because a lot of the mobility is due to commuting. And in fact, the next analysis that we did was analyzing the labor mobility. So what percentage of the population left their area of residence to go to some other area of residence during working hours. And we found a very significant drop in the labor mobility when comparing the labor mobility during the pandemic versus the labor mobility on some working days in November of 2019, before the pandemic. And we observed that on average, there were 60% less people outside of their area of residence during working hours during the first wave of the pandemic when compared to this reference period in November of 2019. As you can see here, not all the regions had the same decrease in the labor mobility. The greener the color, the larger the drop in labor mobility. So some regions like this one here had a huge drop in labor mobility, but then some other regions like this one's here on the interior that had a less significant drop. Because we had incoming flows and outgoing flows, we could compute the activity levels of each of these areas, and we compare the activity levels to the activity levels of the baseline day in November of 2019. And here what we show is the drop, the difference between the activity levels during the pandemic and a baseline day in November. And again, the greener the color, the larger the drop. So we find that some areas like these ones here had a drop that was around 90% drop in activity levels. And then there are some other areas that didn't have such a significant drop. And this is at the very beginning of the pandemic. When we look at what happened when we had the more severe lockdown in the first 2 weeks of April, we find that the map becomes a lot greener, meaning that there was a much more significant drop in activity levels. We performed the same analysis for each department of health. Here we have all the departments of health. This is the geographic regions served by each hospital in the community. And here in orange, we saw the activity levels in November of 2019. And in yellow, we saw the activity levels during the first wave of the pandemic, during the confinement. So we can see that there was a very significant drop in the activity levels. So just to wrap up, we did find a very significant drop both in labor mobility, in activity levels, and a very significant percentage of the population staying in their area of residence during the confinement and during the first wave of the pandemic. A very important component for all this work is to be able to visualize the results and to create an interactive tools so the policymakers can actually see the data and select whatever data they are interested in. So we developed this visualization tool where the policymakers can click on whatever municipality they want, they can click on the time period that they want, and then they can see the different variables, the percentage of population that stayed at home, the labor mobility, the activity levels, and so forth. Because we have incoming and outgoing flows, we can create a mobility graph. And from such a mobility graph, we can run community detection algorithms to identify what we call mobility communities. And these are geographic regions that are very self-contained, that have a lot of inner mobility, but don't have a lot of mobility with other regions. This analysis is important if the government is considering applying partial confinements, because it's important to know what impact the partial confinement would have. According to our analysis in the Valencian region of Spain, there are 14 of these communities. These are geographic regions that have a lot of inner mobility, but are not very connected with the other regions, so don't have a lot of crossovers with other regions. So confining those regions wouldn't have a lot of impact in terms of, disrupting the population, because they seem to have a lot of inner mobility, but not that much with other regions. The second large area has been developing computational epidemiological models. And here we have developed 3 kinds of models. The first one is a more traditional SEIR compartmental metapopulation model. This model divides the population into 4 states, and the dynamics of the system is given by a set of differential equations. So initially, everyone in the population is susceptible to getting the virus because it's a new virus and we didn't have any prior immunity to it. With a certain probability, the population is exposed to the virus. Of course, this probability is proportional to the incidence of the disease at the time. With a certain probability, the people that are exposed get infectious and infected. And with a certain probability, they get retired from the system because they recover or because they die. For COVID-19, these are the standard set of equations for a SEIR model, and then the parameters depend on the disease. And then for COVID-19, these parameters have been estimated, and we tune them to the Valencian region of Spain. We also expanded this model to take into account the mobility of the population, and we have been running this model every day to make predictions on the number of cases and the number of active cases. The second model that we developed is an agent-based epidemiological model. In this case, instead of modeling metapopulations, we actually model every individual as an agent. There are 5 million individuals then, 5 million agents, and each individual has an age and a gender and a contact matrix. And also underlying, there is a SEIR model that also defines which state the agents are, if they're susceptible, if they are infected, and so forth. Using this model, we can also run simulations and predict the number of cases, the number of hospitalized, the number of intensive care units, and the number of disease. And the model that we used was based on a framework called the REINA framework. And finally, at the end of 2020, we developed a new computational epidemiological model using deep neural networks in the context of the XPRIZE Pandemic Response Challenge. So the XPRIZE Foundation, in collaboration with Cognizant, they launched a challenge, a global challenge, where there were two big tasks to do. The first task was to predict the number of COVID-19 cases in 236 regions and countries in the world, up to 180 days into the future, and taking into account all the different interventions applied in each of these regions and countries. And the second big task was to actually build a recommender of measures, a little bit like an artificial politician, and an intelligent system that would, given a certain country and a certain epidemiological situation in the country, would actually recommend a set of public policies that will have the best trade-off between the cost of the public policy and the number of COVID-19 cases that would result as a byproduct of applying that policy. So for predicting the number of COVID-19 cases, we decided to use a different approach. So we used recurrent neural networks, particularly LSTMs, and we developed an architecture where we had two sort of like banks of LSTMs. On the top, we had different LSTMs modeling different regions of the world. So we clustered all the countries and regions of the world depending on the dynamics of the number of cases. And then we developed a different LSTM depending on the dynamics. And then on the bottom, we had a channel, another LSTM that was modeling the interventions. So the A means action. So the different measures that were implemented in each country and region of the world. And the idea is that this layer here, this network here, influences and modifies the prediction on the number of cases. During the competition, our predictor did pretty well. This was, we had to be predicting during Christmas and after Christmas of 2020, 2021. And we did pretty well in terms of the mean rank globally. And I think our predictor was ranking in mean rank the first in the European countries and the Asian countries. But then more importantly, we were able to use this predictor during the third wave of infections, which were the worst. It was the worst wave in the Valencian region of Spain, and it happened in January of 2021. It was a very severe wave, and there were very stressful weeks because the cases kept growing exponentially, and we needed to know when we were going to reach the peak, and also if the confinement measures were enough or not. And here I show the ground truth on the number of cases. In blue is the prediction of our model, and in red is the prediction of a baseline model. So our model was a lot more accurate in predicting the day when the peak would take place, and also the number of cases at the peak. So that was helpful to sort of like for the government to determine whether they needed to implement more measures or the measures were going to eventually work. As I mentioned, as part of the XPRIZE competition, we also had to add a new layer to our architecture, which is this pink layer, which was a recommender of policies. So we had to come up with a system that for each of these 236 countries and regions in the world would identify what is called the Pareto front set of solutions. So each of these dots here is a set of policies for a certain country, and the axes are on the right hand, we have the cost of implementing these policies, and on the y-axis we have the predicted number of cases. And the idea is that each of these dots here is the policies that for a certain cost would give the lowest number of cases. So depending on how much money a country is willing to pay, of course, there are different policies, but also it depends on how many cases the country is willing to accept, or to absorb. So we had to do that for any time period and for each of the 236 countries and regions in the world, and also for any cost, for any potential costs, because obviously the cost of shutting down tourism is not the same in Spain than in a country that doesn't have a lot of tourism, for example. So we did that, and we also built a visualization in Tableau where you could select the country, and then it would show you the policies that the system would recommend for that country. And here it shows the activation level for each of the different dimensions of the policy. So the policies had 12 dimensions. For example, school closing, workplace closing, canceling public events, restrictions on gatherings, and so forth. And each of these different dimensions had different activation levels. And what we had to come up is with the levels of activation for each of the 12 different policies to apply. And in the spring of 2021, the X Prize Foundation announced the winners of this competition, and actually we were the world winners. So that was really encouraging to the team, and I think it's the first time that a team from Spain wins an X Prize competition. So that was really very, very exciting for us. We've also done studies on the impact of contact tracing using the agent-based model, where we found that even if we just contact trace 40 or 50% of the infected individuals, we were able to flatten the curve. But of course, this assumes that everyone can self-isolate, something that we know is not the case. And since the late spring of 2021, we have been sort of like adding both to the agent-based model and to the deep learning-based model the vaccination policies, so we can actually make more accurate predictions now that there are vaccines available for a large percentage of the population. The third working area is building predictive models, mainly of hospital occupancy, intensive care occupancy, also cumulative incidents in each of the departments of health. And this is, of course, very important for policymaking, because one of the biggest impacts of the pandemic is on the healthcare system, and the policymakers need to make sure that they will have enough beds and enough respirators and enough intensive care units for the anticipated number of cases. So we build different kinds of models, including also models using recurrent neural networks, LSTMs, to predict the intensive care and hospital occupancy. And we also did a model to infer the prevalence of the disease. And this was particularly important when in the late spring of 2020 or during the spring of 2020. So there was this big question at the time, which was, have we reached herd immunity? And we didn't know, because there weren't tests available at the time. So it was very difficult to know how many people were really infected with the virus. So to be able to help answer that question, we developed 3 different methods to infer how many people had been infected with the virus during the first wave. The first approach was by building a generalized linear model from the answers to the survey. So we deployed this large-scale survey, and some of the questions in the survey were about gender and age, and the presence of an infected individual in the home, and also the symptoms. So based on that, we built a model that, by analyzing all the answers to the survey, it could infer how many infected people there would be in each of the in each of the autonomous regions in Spain. So we did that, and we did 2 models, one that was only using the symptoms, another one that was also using these variables like the presence of a member of the home infected. And we infer these levels of prevalence, which of course are very much below the desired 65–75% of prevalence. And we also could validate it later on, a couple months later, with a seroprevalence study that was done officially by the government. And our estimations were actually very aligned with the seroprevalence study. So according to this model, we were very far away from herd immunity. The second model was analyzing both the reported number of deaths and the excess of deaths. And in both cases, we infer that for the Valencian region, the prevalence was between 1% and 3%. So that was really low, way below the desire to achieve herd immunity. And the last model was using our SEIR compartmental model. Our SEIR compartmental model has a percentage of population infected, which is shown here in red. And then in blue is what we call the reported, because we knew that there was a gap between how many people were really infected and how many reported cases there were, because there were no tests for everyone. So according to our underlying model, which is this red curve here, there will be roughly 2.3% of the population at the time that had COVID-19. So our answer, according to all these methods, was that we were very far from herd immunity, and therefore, as soon as they were lifting the measures, there will be another wave, which is what happened. So that was also helpful for the government to understand that, there was no victory, on the virus. And finally, in March of 2020, we deployed a very large-scale citizen survey, which has proven to be an extremely valuable tool to really understand the situation and the perception of people during the pandemic. So this survey was launched because there were a lot of questions that we couldn't answer with the data sources that we had. For example, what is the social contact behavior of people? What is the resilience of the population towards the confinement? What is the economic and the labor impact? What is the psychological impact? What's the prevalence of symptoms? Are there enough tests? Is contact tracing working? What kind of individual protection measures do people use? What kind of mobility, like are people taking public transport or not? I mean, there were so many questions that we decided to launch an online survey. So we designed the survey. We invested a fair amount of work, very intense work in mid-March in designing the survey, and we finally launched it at the end of March. It is in multiple different languages. I don't think we have it in Greek, but if any of you is interested in translating it to Greek, please contact me. And the survey is completely anonymous. It has 26 questions, and it is very, very, very helpful. This survey has now over 700,000 answers. The first week of deployment, we got more than 140,000 answers, mostly from Spain. So we felt so overwhelmed by the number of answers, but also we felt obliged to sharing the results. So we analyzed the data very quickly, and we share the data in this SEIR publication. And we also drew 10 key conclusions from analyzing the survey, and these conclusions actually still apply today. So wave after wave, most of these conclusions actually still are valid. We also developed 2 different visualization tools of the answers of the survey, an initial one using Esri, and then the more recent one using Tableau. This is the one that we update regularly every week with all the answers. So if you are curious, you can just go to this website and play with the answers of the survey. We also have a number of publications about different elements, of the survey. And I wanted to share with you some of the more interesting sort of like results and observations. The first one is the perception of the government measures. So we asked people if they think that if the measures are enough, the government should do more measures, if they are excessive, or if they prefer not to answer or they don't know. And as you can see, for Spain, this is since the beginning of the pandemic. The more popular answer always has been that the government should do more. And only very recently, after the summer, people were starting to feel that the measures were enough. However, now, because cases are going up again, there is again more demand for doing more measures. This behavior is actually quite different from other European countries. For example, the answers from Germany. So in Germany, it was the more popular answer to do more, and these waves actually match sort of like the waves of infections. But then since the spring of 2021, when vaccinations started, it has been pretty similar, the percentage of people saying that the government should do more or that the measures are enough, until this massive wave of infections that started in Germany a few weeks ago, where there is this massive demand for more measures, as you can see here. We also have information about which protection measures people adopt, and we also observe country differences and gender differences. So here we show the percentage of women in red and the percentage of men in blue that report doing these different adopting these different protection measures, from disinfecting hands, wearing face masks, avoiding crowds, and so forth. So the first observation is that women are a lot more compliant than men in all the measures, except for using the app. So women disinfect their hands a lot more, wear face masks a lot more, avoid crowds a lot more, etc. These percentages are much lower, very significantly lower than they were 6 months ago. 6 months ago, there was a lot more compliance with the measures, and we can see the impact of the vaccination and also the impact of the pandemic fatigue. People are really tired of having to adopt these measures for so many months. We also observe a very significant willingness to get vaccinated in Spain. And this figure now is low. It has been for many, many months on an average of 93, 94% of the population being willing to get vaccinated. And I think that has been an incredible positive response in Spain that has made Spain be one of the countries in the world with the highest rate of vaccinated population. When we look at the same question or the same answers from Germany, we have a very different picture. First of all, we see that the percentages are much lower, much lower. For example, only 38% of the German men report wearing a face mask versus 66% of the Spanish men. So that's almost like, you know, half or 40% less. We see again that women are a lot more compliant than men. And we observe a very low intention to get vaccinated, many points below the intention in Spain. When we look at why, the main reason why the German respondents report not wanting to get vaccinated is because they don't trust the intentions of the government. We can see here geographically the differences, and we can see how Spain and Italy are a lot greener with much larger intention to get vaccinated than Germany. And in Germany, we see a big difference between the former Eastern Germany states and the Western Germany states. We also have the evolution over time on the perception of risk of different activities. We ask people, which of these activities do you think you could do with low risk of getting COVID-19? And the one that has always been estimated to be the safest is doing sports individually, which is this gray line, which makes sense because if you are doing sports individually outdoors, the likelihood of getting COVID-19 is very low. And the activity that throughout the entire pandemic is considered to be the least safe is flying by plane, even though there hasn't really been a lot of reported outbreaks in planes, but it's interesting how it is the one that is perceived to be the least safe. I think there is a large correlation between the perception of risk and what people do. And because we have been confined and we haven't really flown by plane, maybe that's why also we think flying by plane is not safe. And we can see evidence of this in this red line, which is going to the beach. So going to the beach in the winter months was considered the least safe. And then as the weather started being nicer and in the summer of 2021, the perception of risk in the beach the perception of safety of the beach went up a lot, reaching the peak in the summer of 2021. So there seems to be a correlation between what we do, and what we think is safe. When we compare with the data from Germany, one observation, the ranking is very similar. In Germany, also flying by plane is considered to be the least safe, and doing sports is considered to be the safest. But we see that the percentages are lower for the upper part, and they are higher for the planes. For example, the planes in Germany is like above, almost like 35, 38%, above 30%, in many occasions they are considered to be safe, whereas in Spain is really low. It's been like much lower. We know that a key pillar in the test, trace, isolate mitigation strategy for COVID-19 is the ability to self-isolate. So since March of 2020, one question asks respondents if they would be able to self-isolate if they had to, because of COVID-19. And week after week after week, we get very similar results. The first observation is that for the people aged 59 and younger, roughly half of them, they say that they would not be able to self-isolate. So that's a big percentage of the population. Luckily, for the elderly, a much smaller percentage, less than 30%, say that they would not be able to self-isolate. But we do see a significant percentage of the population having trouble to self-isolate. The main reason is because of sharing the home. But we observe gender and age differences in the reasons why not. Very significantly and very prominently, among the youth age 18 to 29, the psychological reasons are important. Fear of stigmatization and being psychologically impossible to be confined. And also we observe a significant gender difference between men and women. Men are on the top and women are on the bottom in the people age 30 to 59 regarding not being able to self-isolate because of having to take care of children, where 28% of the women, but only 13% of the men say that that would be the reason. So we see how the burden of childcare relies on women today. When we look at Germany, we have very similar results with much more significant percentage of the population reporting not being able to self-isolate. And again, the youth reports is the most likely group to report psychological reasons not to be able to self-isolate, but with a much larger percentage. And then the gender differences are huge for having to take care of children between men and women. And finally, we also have data on how successful or how useful the contact tracing apps have been. And here I wanted to show you the data from Spain and Germany as well. So from a sample of almost 140,000 people, roughly 30%, they report having the app installed. So that's a very high percentage. We have a pretty technological, I guess, sample. Out of these 30%, which is 42,000, roughly 7.7% report having had a close contact with an infected individual because they know, because the infected individual has told them, or they have been called by the contact tracers, or they know that they have had a close contact. However, these are 3,241 people. However, only 86 discovered that close contact thanks to the app. Of those, only 27 got tested, of which only 7 were positive. So we see that out of an initial sample of 139,000, the app helped identify 7 positive cases. For Germany, the percentages are a little bit better, but it's still quite small. So the sample is small, it's smaller, 55,000 people, of which almost 21,000 report having the app, of which 929 report having had a close contact, of which 174 report discovering from the app. However, and this is one of the weakest elements, out of these 174, only 53 get tested and only 10 tested positive. So what have I learned throughout with all this work, during all these months? So I think the first learning is a very obvious one, but I think it's important to remember it. And it's like a pandemic is not just a public health issue. It is a societal challenge, and it requires a holistic, multidisciplinary approach. And this is very important. The second learning is that we do have an opportunity to create a virtuous cycle between data, technology, people, and policymaking, but I don't think we have such a cycle today in most cases. We still have to invest into creating systems where data is systematically captured and analyzed, systematically, automatically, so we can actually understand where we are, why we are where we are, and where we might be going. We also need to invest in the necessary human resources empowered with the right technology. So, contact tracers and doctors and healthcare workers and researchers and teachers and so forth, but they also need to be empowered with the technology to be able to do their work well. It doesn't help if the contact tracers are using tools from the 1990s because it doesn't really scale. And of course, all this data and all these people, one of the elements that, one of the values that they bring is to actually support the development of public policies that would actually tackle the weaknesses that we identify through all this process. For example, if we know that more than 50% of the people aged 59 and younger cannot self-isolate, probably we should deploy programs to support self-isolation. If we know that the youth is the group that is the most psychologically impacted by the pandemic, we should probably deploy programs to support the youth, and their mental health, and so forth. We reflect on this intersection between data, technology, and COVID-19 in this policy paper that I wrote in collaboration with Data-Pop Alliance and the Vodafone Institute. And it's a relatively long paper, it's publicly available. And we sort of like put forward some key recommendations to from the learnings that we have from this pandemic, but also to sort of like prepare and be better prepared, for the next pandemic whenever it would come. We also have a lot of scientific publications describing our work in more detail. Wired featured us a couple months ago, telling our story. So if you don't want to read the papers, but you want to read more like the story, there's also this article. And then describing the X-Prize recurrent neural network models. We have this paper that we presented a couple of months ago in ECML PKDD, and we actually won the best paper award in the data science track. So this is all I wanted to share with you, and I thank you for the invitation and for your attention. And I also encourage you to respond to the survey. And particularly if any of you would like to launch it in Greece and translate it to Greek, please contact me later. So thank you very much.